To all of you, welcome to Healthcare for All's monthly speaker series. My name is Peter Lucas. I'm a practicing physician who volunteers as treasurer of the board of directors of Healthcare for All Washington. And tonight's presentation is very special to me as I previously served on a team of Peninsula Community Health Services in the West Sound as a psychiatric consultant for the collaborative care team there. That's what we're going to be talking about tonight. And I was trained by and consulted with tonight's speaker, Dr. Ratzliff, for several years and observed firsthand how effective the collaborative care model is. And healthcare advocates have recently been addressing the valuable role of primary care providers in a true universal healthcare system. I mean, they will really be the foundation of such a system. We recently heard from Dr. Stephen Kemble from Physicians for a National Health Program talk about the role of collaborative care model as a strategy to move us forward on the universal healthcare pathway by improving services of primary care providers. In addition, Jane Beyer just presented a proposal for universal primary care to our allies in the Healthcare Authority. And tonight we expand on those two ideas with a presentation by Dr. Anna Ratzliff from the Psychiatry and Behavioral Sciences at the University of Washington Center for Advancing Integrated Mental Health Solutions, which is a mouthful, so we just call it AIMS. Ronnie?
Thanks, Peter. So in this chat, in our Zoom chat, we will be posting a link to our website where you can find our donate button and then navigate to get involved in different actions. You can volunteer on a committee. You can volunteer on a specific project. We'd love to have you involved. So there's a couple of reasons to watch the chat, to look for that donate button. We will be entering it throughout the meeting. And every donation moves us a step closer to universal healthcare, to a true universal healthcare system. We've set a goal to raise $250 during the program tonight. So you can go to the chat at any time during this presentation and make a donation or get involved. That's a donation too. We will add the resources and the information that Dr. Ratzliff is sharing with us tonight on our website, so you can check that out to see the details in case you missed something. But it also has our legislative goals, our long-term vision, our strategies, a universal healthcare pathway, the way to get to a true healthcare system with everybody in and nobody out. So there's several reasons to look at our website. You can also use the chat, which is where we will track any questions. So if you go to that chat and add your question, we will have a Q&A session after the discussion tonight. So please enter questions there. Also, note that you can click on the closed caption icon at the bottom of your Zoom screen. If you click on that, you can get the caption running across, the closed captioning. Sorry. So I would like to share that I'm participating in this Zoom meeting tonight from the lands of the Coast Salish peoples. Please take a minute to acknowledge the peoples in the lands where you're joining us from today. We acknowledge all of the ancestral homelands and traditional territories of indigenous peoples who have been here since time immemorial. We walk that pathway to universal health care together with indigenous people who created or who have watched over this land, to remember the lessons of life and to preserve our land. We thank the Coast Salish peoples of this land, the land which touches the shared waters of all tribes and bands within the Duwamish, Muckleshoot, Puyallup, Suquamish, and Tulalip nations. So let me pass this back off to Peter and welcome Anna, and I will disappear. But please use the chat to enter your questions and to check out our website. Thank you.
Okay. Peter, I can't hear you if you're trying to share something.
You're muted.
Good. Okay, how's this?
Perfect.
All right, right. Well, I'm just going to read her bio here. I don't know how I got disconnected. Where is it here? Uh, there we go. Um, Dr. Ratzliff, MD, PhD, is a national expert on collaborative care and specifically on training teams to implement and deliver mental health treatment in primary care settings. Her passion for translating complex research ideas into practical real-world applications began when she received her MD and PhD in Anatomy and Neurobiology as part of the Medical Sciences Training Program at University of California at Irvine. She's currently a professor and vice chair of faculty development in the Department of Psychiatry and Behavioral Sciences at the University of Washington, where she has developed additional expertise in suicide prevention training, mental health workforce development, adult learning best practices, and mentorship. She's co-director of the AIM Center and director of the UW Integrated Care Training Program for residents and fellows. So I think that's it. That's it for the introduction.
Great. Let me make sure my screen is actually sharing with all of you. I think it's going now. Is that right? Everybody can see it?
Yes.
Got it. Got it.
All
Yes.
right, great. Okay. Well, thank you so much for inviting me. I'm really excited to be here and share a little bit about the collaborative care model today. I love questions as an educator, so please feel free to use that chat. If I see them come up and I can just integrate them into what I'm talking about, I'll do that. Otherwise, I'm looking forward to having some time to answer questions at the end. And today I'm going to talk about collaborative care, which I really think is an amazing model of care that can be used to support primary care providers, improve access to high quality mental health services, and really be an opportunity to improve health equity. I also want to say, as I talk about the collaborative care model, many of the components of collaborative care I think can be very useful, even if you're not delivering the whole model. So happy to talk about that as well when we get to Q&A. Okay, so let's make sure this can move forward. So I always start here, which is why am I talking about models of care to deliver mental health services in primary care settings? And that really is around trying to increase access to care, which I think this group would be very oriented towards. And this is because mental health disorders are really common. Probably about 20% of the population experiences a mental health illness in any given year. These data are from SAMHSA from around 2019. About half of the people who have a mental health disorder do not receive any treatment, which is a lot of people every year not experiencing any access to care. And some of those patients aren't seeking care, but a good half of those, again, are wanting care and cannot access that. And this number really hasn't changed despite all of our efforts to improve access to mental health services since the mid since 2011. When we start to think about where there are opportunities to intervene, I think it's really important to be talking about primary care. And that's because right now, that is where most people receive their mental health services in the United States. About 60% of people will receive their mental health treatment in primary care settings, with only about 40% of the population actually accessing specialty behavioral health. And that's generally a single visit with a psychiatrist, mental health counselor, some other kind of specialty mental health provider. So in many cases, people are really, primary care is the main and only access to mental health services people will receive. Um, a lot of people ask me, well, why aren't we just working on improving referrals? And I think there's two main main reasons why people need more access to care in primary care setting. The first are really patient factors. A lot of people who are given referrals to care don't follow through or don't actually get connected to care. I think that's a combination of patient preference and honestly just the complexity of following through on referrals. Sometimes it's very hard to actually get connected to services. The other thing is really provider factors. About 50%, a little under 50% of the counties in the United States don't have a psychiatrist. And so that means, and that's represented on this map here with the gray showing all the counties where there is no psychiatrist available. And you can see that that disproportionately especially affects some of our rural communities. So this is really important for Washington State and beyond. So what are some ways that we can start to address some of these needs? I really think of integrated care models where we're bridging that space between patients kind of doing it on their own or primary care doing it on their own and specialty behavioral health as a really important area to increase access to both quality of care and just any care. Collaborative care is a specific model of integrated care, and I'll talk more about what that looks like as we get into the next couple of slides. The other opportunity I always like to talk about on this slide is that I think it's really important to increase access to integrated care because there is so much pressure on our specialty care, community mental health centers and hospitals. There's just not a lot of access there. And if we could actually address some of the needs of the patient population in integrated care or collaborative care models, we might be able to pull off some of that pressure from that specialty care setting and actually be able to provide better service across that whole continuum. That, of course, also would require good coordination of care, which can sometimes be challenging. So that isn't a totally easy thing to do, but definitely something that's aspirational. Okay. So what is the collaborative care model? This is a slide that I think does a nice job of sort of talking about the core features of the collaborative care model. So the collaborative care model really starts with the idea that there's a primary care provider and a patient, and that support is going to be added to that dyad to really help more consistent mental health care, higher quality mental health care happen right there in the primary care setting where often patients are most comfortable. So the first thing that collaborative care adds is a behavioral health care manager. This is generally someone who has specialty behavioral health training. Typically, it's a master's level person, although I'll talk a little bit about a bachelor's level behavioral health workforce in Washington State that I think could be a real addition to many teams. That role has really two specific functions. The first is to coordinate the care of the whole team. And the second is to deliver brief evidence-based psychotherapy right there in primary care. So they don't have to get referred out to some other place to receive evidence-based psychotherapy, which is often a preferred and first-line treatment for many patients. The other main person that gets added is a psychiatric consultant. This could be a psychiatrist, psychiatric nurse practitioner. Typically, those folks are not actually seeing the patients directly, but leveraging their expertise in a weekly meeting with that behavioral health care manager, where they provide guidance on both treatment diagnosis and treatment recommendations for patients. Those are generally called, this is called a systematic caseload review, and those are recommendations that are given to the behavioral health care manager and the primary care provider. In this case, the primary care provider is typically prescribing medications if that's indicated and preferred by the patient, while the behavioral health care manager would be delivering any psychotherapy. Some key features of collaborative care and some requirements, and I'll talk a little bit about billing later, are that the team is using a registry to track all the patients that have been identified as needing services, that patients are offered that full range of evidence-based treatments, including both psychotherapy and medications, and that whole team is using measures like the PHQ-9 for depression to make sure that the treatment response is tracked over time. And those are some really important core components to the outcomes that I'll talk about in the next couple of slides. So this model has been around since the early 2000s, and the largest trial to date is still the IMPACT trial, which was actually conducted out of the University of Washington by Dr. Jürgen Unitzer. And I'll show you on this next slide the outcomes from that trial. That trial had 1,801 patients actually involved in it. It was actually older adults that had major depressive disorder. And what they found is in the 8 organizations that participated in that clinical trial, patients were randomized to either collaborative care, as I just described it with that whole team, or usual care, whatever was provided in primary care. So that could be referral out to people, that could be the PCP prescribing the medications kind of on their own. That could even, in the case of, I think it was organization number 6, referring to a therapist down the hall. So patients were still that was usual care. But in every case, collaborative care, organizing the team the way I just described, outperformed usual care by about twice as effective. So at every site. And so this is a model of care that has really been evidence-based to improve the clinical outcomes for patients, in this case for depression. Since that time, there's been about 100 randomized control trials that have been done exploring the collaborative care model, and I'll talk about those trials over the next couple of slides. I think one of the things that's really important to understand is that across these 5 domains, the quintuple aim, collaborative care really outperforms usual care. So as I talked about in the last slide, increases access to care through being delivered in primary care settings, also improves clinical outcomes. So twice as many patients are improving. We have good data that this can actually reduce total costs of care. So in the original IMPACT trial, they monitored the patients for the next 4 years after the trial. And what they found is that over those 4 years, there was a total reduction in overall healthcare spend, and especially on inpatient hospitalization for medical conditions, non-psychiatric conditions, yielding about a $6.50 to every dollar spent return on investment. I think one of the things that I really want to emphasize that this is a model that can really help primary care providers. And so we've gotten really good data that there's good PCP satisfaction. This is actually one of the quotes from one of the PCPs that was involved, where they really talk about having that team to help support them and really provide that follow-up was much more intensive than what they could provide on their own. And that was really, I think, experienced as very supportive to the primary care providers. Patients really liked getting care where they were comfortable getting and obviously getting better. And then we have good data that this may actually reduce the health disparities that are often seen in mental health services with patients from racial and ethnic minority, as well as some of the other disparity populations having equivalent or even sometimes better outcomes than their control populations. And this is some of that data. This was actually from that original IMPACT trial, where you can see that both the Black and Latinx populations received about the same outcomes, if not maybe even a little better than the white control patients in that trial. So as I said, there's now been over 100 randomized controlled trials, including some meta-analyses of collaborative care for depression treatment in both US and Europe. And over all of these trials, what you see is consistently more effective than usual care outcomes when care is delivered the way that I described. We now have also seen that this is true across many diverse populations and settings. So this is true for perinatal, adolescent, older adult, patients experiencing cancer. This can be true in rural communities, low and middle income countries, as well as care delivered at federally qualified health centers or patients that have lower income. So this is really just emphasizing that this is a model that now has been widely tested in a wide variety of settings and contexts and continues to outperform usual care in all of those situations. It's also exciting that collaborative care has now been shown to be more effective in conditions outside of major depressive disorder. So that list has actually gotten pretty long now. You can see here that that's for a wide variety of different kinds of depression, for anxiety disorders, post-traumatic stress disorder, PTSD, chronic pain, dementia, substance use disorders, including co-occurring opioid and common mental health disorders, and bipolar disorder. There's some emerging evidence in pediatric populations for ADHD. So this is really an approach that can be helpful across a wide range of behavioral health presentations in primary care settings. So that is the model in a nutshell and a little bit of the evidence base. And what I really want to spend the rest of my time talking about is our experiences at the AIM Center at the University of Washington. So the AIM Center was founded a little over 20 years ago by Dr. Unitzer, who's now the chair of our department. Essentially, once they had those positive findings from the IMPACT trial, people started reaching out to him and saying, hey, I want to do this in my center or my, healthcare setting. And he, like most researchers, was like, I know how to run a clinical trial. I don't really know how to make this happen in the real world. So actually received a grant to found the AIM Center, and we now are a self-funded center that works nationally and internationally to help organizations implement collaborative care. And we've supported delivery of these services in now hundreds of clinics. So this is we now have a lot of experience about how do you make this happen in the real world. So what I'm going to talk about is a few of the things we've found to be helpful in the way that we approach implementation. And I'm going to also talk a little bit about some of the policy things that have happened over the last 10 or 15 years that have really helped promote the uptake of collaborative care, because I think those might be really interesting to this group who thinks a lot about how do we make some of these changes happen at scale to really help influence the health of our population. So one of the first things that we realized is that collaborative care, unlike in a clinical trial where you have to really make it look the same everywhere, probably looks a little different in each clinical setting. And so what we did is look across actually all of those probably first 70 trials and kind of tried to say, what is the secret sauce? What do we think are the things that absolutely have to be in place to get the kind of outcomes that we see in clinical trials? And those are these 5 principles that you see outlined on this slide. The first is that you're using a population-based approach. That means that you're identifying all the patients who really need these services and tracking them in a registry. That's really important because it makes sure that you don't lose track of any of those patients and they sort of fall out of care, which is a really common reason why people don't get better when they get identified with depression, for example. And that makes a lot of sense because primary care often is a much more reactive kind of environment. You take care of the sick people who come in asking for help. And the problem is with depression is that when you get sicker, you get deactivated, you get less likely to come into your primary care providers or provider's office. And so having a more proactive stance about really saying once someone's identified, we're going to be pretty aggressive about trying to go out and get them engaged in care makes a really big difference in their outcomes. The second thing is we're going to use those measures and do measurement-based treatment to target. So using something like a PHQ-9 in addition to our clinical judgment. And that's because there's really good data that when you routinely use measures to inform your treatment decision-making, you're more likely to not stay too long on an ineffective treatment or a only partially effective treatment. The third thing is that we use that team, and that's really important because, as I said, there just aren't enough psychiatric providers, for example, for everyone to see a psychiatrist directly. So using them to really leverage their expertise through that team is a way to give more patients access to that specialty input to their care. We make sure patients are getting access to evidence-based treatment across that full spectrum, so it's a very patient-centered approach. And then accountable care is what I mean by that is that we're actually looking at metrics to make sure we're getting enough people better. And I'll talk a little bit more about metrics when I talk about some of the policy pieces that I think are really important to be driving this type of care forward. So when we at the AIM Center help an organization implement collaborative care, what we do is say you've got to have these 5 principles in place, but you can be a little flexible, who you use as that behavioral health care manager, what patient populations you target, which measures you're using. There's some flexibility in how you do that, as long as you're staying true to those sort of core features of a collaborative care approach. So, are people doing this? This is the big question out there. So, over those last 20 years, we've seen a big uptake in collaborative care. And this is actually Washington State plus a little bit of Oregon. So I blew up this map that's available on this organization called the Path Forward. And what this shows is all the counties in Washington State that are actually utilizing the collaborative care codes. So for sure collaborative care is happening in all of these places. And then the darker that county or region is, the more the collaborative care codes are being billed. Again, this is just commercial insurance. You can click through this and actually look at Medicare, Medicaid, and this gives you a sense of sort of what is the heat map? Where are people actually delivering these services? And when I look at this map, I'm both excited because I see there's some places that are doing a lot of collaborative care and also some opportunity because this isn't happening everywhere in the same to the same degree. And so this is something that we think a lot about at the AIMS Center. And I thought this might be interesting for you guys if you're interested in what's happening in your county. So I think we can send out the PDF or put up the PDF of these slides afterwards, and that has a link to this in there. Okay, so what are some of the things we've seen to be helpful as we try to disseminate this model and get more people to be utilizing it as part of routine care? So I'm going to go through 4 things that we found to be really, really helpful, and some of the places where we've seen this used to inform policy or other measures to help promote the uptake of collaborative care. So the first thing that I wanted to talk about is that clinic systems need help to actually learn how to do this work because it's actually pretty complicated. And so the data on this slide are looking at clinic systems that worked with the AIMS Center, and we had sort of 2 models of implementation. We had basic support, which is that the people used a registry product that we had, so could enter data, get help with that tracking the population part, and then had either a one-day training or just utilize the resources. We have tons of resources on our website to help people think about implementing collaborative care. And then we have clinic systems that we've had the opportunity either because they have contracted with us to get implementation support or we're part of one of our implementation projects where we were able to provide what we called enhanced support. And that's where we really spent about 12 to 18 months working with them to help them implement their collaborative care program. And what we found is that when we actually helped people really work that for about 12 to 18 months, in every way you could measure depression response, significant improvement or depression remission, the clinics that received more support outperformed the clinics that kind of got that basic package. And these data are correlated, so it's not causative. But what I would say is that it really does take intention. And if you have more support to actually help practices learn how to do this, they're more likely to be successful in actually delivering collaborative care. So we've done this. We've gotten some federal funding to support this. We've also had states help fund this kind of technical assistance. We have examples of this in New York. And again, federal legislation. We also offer free office hours to try to offer some people the opportunity to access some of our services. We've also seen nice implementation projects happen. For example, Washington and Alaska Primera, they sponsored a project where we got to help almost 30 clinics implement collaborative care. So we've seen some really nice examples of if people can offer training and technical assistance, that's a real way to promote this kind of uptake of this model. And just to give you a sense of sort of what does that enhanced support look like, this is what our typical map looks like. We spend time with the clinics really making sure they understand what the model is and what they're going to be trying to implement. We spend several months working with them to really work on their workflows and build the clinical skills of their team to work together in a new way. We support them during the launch, where we're often tweaking those workflows and making sure that people can really deliver care this way, as well as helping them really build sustainment. And one of the things that we've learned early is that we always have to think about that sustainment from the beginning, because there's some especially common barriers. For example, how are you going to finance the work of this team that can get in the way if clinics aren't really thinking about that from the beginning? And I think one of the things that we've really seen be a big facilitator, actually, of improving access to collaborative care is actually that there has been some federal billing codes that have been put in place that are allowing people to have a more sustainable approach to delivering care this way. And I'll talk about that in a couple of slides. This next slide. So these are the collaborative care codes. They were introduced in 2017 by Medicare, and then Washington State adopted them, I think, in 2018 from Medicaid, as well as many of our private or commercial payers also will have these codes available for payment. They're a little different than a typical fee-for-service bill in that they actually are billed once a month for sort of all of the activities of the team over that month. And you can see that these aren't super high reimbursement rates, but if you're running a pretty efficient model, I think that this allows you to actually, for organizations to cover the costs of delivering care this way. So been a really important policy implementation. We also, there's recent data that just came out that showed that if Medicaid does pay for this, like it does in Washington State, you tend to see more of the commercial payers also adopting these codes. And so there are still, I think, 11 states across the United States that haven't done that yet. Whenever you can see a kind of nice correlation that once Medicaid is approved in that state, you tend to see a big uptick in the number of organizations offering collaborative care. So this is an important, I think, policy strategy. Okay. The next lesson I'm going to talk about is just training teams to work in different ways. I think that, when I first got on today, I was chatting about the University of Washington and that many people in Washington have actually been trained there. However, I think collaborative care is a relatively new way to work together. And so not all training programs include training and how to deliver care this way. And so one of the things we've really seen is that states that offer training or sometimes payers that offer training in delivering care this way can really help facilitate the uptake of this care to be delivered this way. So for example, Blue Cross Blue Shield in Michigan pays for training for providers that have a lot of their patients being seen in their clinics. We also have had opportunities like federal grants. For example, the AIM Center worked with the American Psychiatric Association and trained about 4,000 psychiatrists across the country in the collaborative care model. So this has been an important policy sort of lever to try to get uptake of the collaborative care model. This figure really talks about some of the key things that the whole team needs to learn about. These are both how does this kind of mental health care look like in primary care settings, but also how do you really work together as a team in a very different way than many of us, again, have been trained to work together in. And I said I'd mention this. I think it's also really important to talk about the need for workforce, that behavioral health care manager role. If you're filling it only with master's trained people can sometimes be a barrier. It can be hard to hire those people, especially in some of our rural or underserved counties. In Washington State, I've been fortunate enough to be involved in developing a new workforce called the Behavioral Health Support Specialist. This legislation passed, I think now 3 years ago, and we have our first BHSS graduates actually this last year. And the idea behind this is that really a bachelor's level person in many settings across the world are able to be trained to deliver brief evidence-based interventions under supervision. And so this might look like a patient coming in, being identified either by a behavioral health provider or a medical provider as needing services, being able to be connected with a bachelor's level person who could deliver a brief course of, for example, behavioral activation for a major depressive disorder. That would be monitored. And if the patient improves, they can kind of return back to care, the care as needed. If they don't improve, then that would probably be a step up to being able to be directly seen by a more highly trained provider. These folks work under supervision. And if you're interested in learning more about this, I'd love to share more with you about this. I'm pretty excited about this program. There's about 10 institutions across Washington State now that have integrated the year of training required to become a BHSS into their undergraduate 4-year degree program in either psychology or behavioral health. And again, I think this is a really exciting new workforce in Washington State. So we're really a leader in the country right now around trying to think about how to do this with a lot of rigor and quality. Okay, third sort of idea that I wanted to talk about is this registry function that I talked about and the need for measurement-based treatment to target. I talk about this because I think it's really aligned with the next thing I'll talk about, which is the importance of measuring quality if you're doing this work. I really think of this first part as like at the patient level. It's really important to be using these measures to inform how you deliver care. So this is a single patient and kind of the course of their treatment. So I'll just chat through it a tiny bit. It's a patient actually that was one of my patients. It was a college student who came in, had a history of depression, and actually had really been struggling, wasn't going to class because they had been struggling with depression. Their PCP recognized that, was pretty quickly able to get them in with the behavioral health care manager in their clinic. And you can see that happened sort of around the beginning of January. At that time, that person had a PHQ-9 score of 15, which is sort of moderate depression at that time. That behavioral health care manager really was able to quickly assess them, determine that they didn't have any substance use disorder, didn't have an anxiety disorder, didn't have bipolar disorder. So this was really a patient with major depression. And over the next 8 weeks, what they basically did is very quickly, go through a couple of treatments. The patient first tried behavioral activation by themselves. That wasn't enough to get them better. As the psychiatric consultant, I made a recommendation for a medication, which that PCP prescribed. It needed an adjustment in the dose. And what you see is about 5 or 6 weeks in, the patient actually talked to the care manager and was finally getting better. They were on a combination of therapy and medication and sort of disappeared for 6 weeks. So between week 8 and 14, you don't see them. But what you see is that during that time, they really got their depression under control. They were able to actually get back engaged in school, which was really important because they were at risk for losing their funding, their financial aid, if they hadn't been able to maintain a certain grade point average. And what you can see is that patients with collaborative care can really get access to high quality care, have a couple of changes happen quickly, and hopefully get back to living their life. And I think that this particular patient, if they hadn't had that rapid access to the care manager, might really have missed that window to actually recover and get back on track. And that would have been really impactful for them, if they hadn't been able to finish their semester. So I really think the registry is a very important tool. We've seen examples in, for example, a project we did in North Carolina. They offered a registry product to clinics and really saw an uptake in the number of clinics who started offering collaborative care. We've also seen some people develop this capacity within their EMR. So that is, again, another really important strategy, I think, for supporting implementation of collaborative care. And the last example that I'll talk about is meaningful metrics to facilitate an accountable care. I know one of the things you guys talk about a lot is not only access to care, but access to quality care. And so I think that this is a really important part of, if we're going to do care in a different way, it's really important that we measure outcomes at kind of that system or clinic level. This was actually looking at a program that was offered in Washington State. I was actually one of the psychiatrists that was involved in this program. It was offered for sort of pre-Medicaid expansion when we had a state short-term disability program, and those patients got a medical benefit through Community Health Plan of Washington. During that time, they started offering collaborative care by supporting a block grant to clinics offering collaborative care. They got a psychiatrist, they got a registry, some money to hire a care manager, and they got a one-day training, and they said, go off and do beautiful things. And what we saw is what you see here on the blue line. This is a survival curve. And what this shows you is it was taking about 72 weeks or almost a little over a year for 50% of the patients to improve. So that was a lot longer timeline than we expected. We really would expect that to be shorter based on the evidence base. So what they did is they actually introduced a pay for performance component to this program. They basically said there are going to be a few metrics. They were all process metrics at the beginning that you're going to have to be accountable to at the clinic level. And we're going to put 25% of that clinic payment to cover the care manager's salary at risk. And what they found is that they didn't, they basically, these were really simple things, build an adequate size caseload, find the patients that need this help, make sure you actually talk to your psychiatric consultant in a weekly time, make sure you follow up with patients in a timely way. And what they saw is over the next year, that time it took for half of the patients to get better dropped to about 24 weeks, which is much closer to what we saw in clinical trials. And so I think this is a really good example of when you're implementing new care, we really need to be monitoring at that system or clinic level that that quality is maintained. So that was a Washington State example. We've also seen this in other states such as New York around their Medicaid program, that this was a really important part of their implementation work as well. What are some examples of the kind of metrics we look at? These line up with those core principles. For example, you got to make sure you're actually getting patients enrolled. You got to make sure you're seeing them. You have to make sure that their outcomes actually start to improve. And if not, that you're actually working well as a team. For example, that number of patients not improved without a case review. And that you're offering things like evidence-based psychotherapy to make sure patients are getting better. So these are the kinds of metrics that I think could be really important. We're also seeing that there are national quality metrics around depression. I think it's really important that Washington State has been moving in the direction of really committing to depression remission or response and not just screening when we think about how do we improve quality of care. That's because this measure makes sure that patients are actually not just getting identified, but actually getting good treatment, and that clinic systems are responsible to actually demonstrate that they're getting patients better. So these are some important levers, I think, in policy to be thinking about as we're trying to think about how do we promote these models and this access to mental health services in primary care settings. So that was sort of a whirlwind, but I hope that it was helpful. I think there were a couple of questions that came in, so I'll look at the chat now. I also just want to say I work with an amazing team of people, and these are most of them in the slide here at the AIM Center. Much of the work that I've shared with you comes from partnership with them and some people that are no longer with us at the AIM Center. So always want to acknowledge that the work I'm sharing is the work of many people. If you're interested in learning more about what we do at the AIM Center, I've put our link to our website here. Washington State funds us to offer training. We have primary care provider training as well as psychiatric consultant training and care manager training available at the AIM Center and at the Integrated Care Training Program. And if you're interested in some of that training, if you're have psychiatric providers that that want to learn more about this, that is available through the American Psychiatric Association website. So I see a few questions. So I'm going to just go back up to the top of
So
them.
why don't we give you a few minutes, Anna,
Yeah.
to go through those questions? Peter, you want to jump in and offer thanks for like a great, not just an evidence-based care, but an evidence-based system, a way that we actually can improve our current healthcare system. Peter, you're muted.
Yeah, I was involved with collaborative care for quite a few years and saw it work very well for very many patients. And the AIM Center has really just worked so hard at this to get to develop this model and to spread the word. So I think this is really good. And of course, if implemented in the setting of a universal healthcare system, could be one of those factors that reduces costs and improves availability and outcomes. So this could fit in very nicely with the universal healthcare system. Of course, a plug for ours, which is single payer government sponsored healthcare system.
Yeah, and I think that this is an important part if you're thinking about a single payer, because you really want to be able to offer high quality mental health care, because it's going to help contain the costs of the overall health care of our population. So yeah, I just, reinforcing, and reiterating some of that. So
So
great.
let's take 1 minute. If you could stop sharing, Anna,
Yeah.
and just let me ask each of you to, if you are able to make a donation, to go to our website. You can see the link in the chat, and if you, we are really appreciate the help and the work that we're trying to do to get legislation passed, to do non-legislative support for the healthcare authority and the insurance commissioner, and the work that our state is doing already. It's so powerful to see the University of Washington's role in supporting each of those. This has been a great example tonight. We are asking you to help support us. Our goal is to fund healthcare in our state. And so any donations you can make to fund us can really help in that process. So if you take a minute, in addition to adding another question to the chat, go into the chat, look at our website. If you are able to make a donation, we have a C3 fund. If you have a tax protected donations you want to make, we have a C4 fund which focuses more on our legislative activities, and you can make a recurring donation. Even small amounts do mount up and make a difference. So thanks for joining us tonight, and please continue to add questions into the chat, and look at our website. Bookmark it on your computer. Thank you for past support, and let me thank you for the future support to help making this happen. So I'm going to move out of the screen and add, well, before I move out, let me introduce one other person to help support Anna in making this go smoothly. John Sobeck is a former OBGYN who has become very involved in health strategy and has had a long career in our state. And he's now the vice president of our organization. So Peter and John, if you could help Anna identify the key questions to work on, let's keep adding them to the chat. So thank you.
So Anna, do you want to just read them yourself, or do you want us
I mean,
to,
I can start at
or
the
do you want us
top,
to narrate?
and if you want me to go forward to a different question, let me know. I mean, the first one was about, is the collaborative care model being used in the UW primary care system? Yes, it is implemented in the primary care system in the primary care clinics. Each of them has really a combination of the collaborative care model plus some co-located direct services by psychiatry. So that is available in the University of Washington system. And I think why is because, this is an evidence-based model. The next question was really talking about how does this differ from a patient-centered medical home model? I would really consider it complementary to a patient-centered medical home model in the sense that often that is really starting to think about the whole person care, and this could be one of the strategies to make sure you're addressing depression and some of the the HEDIS measures around depression, especially if those are targets that your patient-centered medical home is focusing on. So I really see them as complementary. It's really a model that can fit within an ecosystem of behavioral health strategies that any primary care system is delivering. I think the third question really focuses on licensed psychologists being involved in the work. So I'll talk a little bit about that. We definitely have licensed psychologists as part of our team. A lot of the time, they have been more focused on actually supporting training of our behavioral health care managers in the evidence-based brief behavioral interventions. Although in some systems, behavioral health care manager role might be filled by a psychologist. They often collaborate in that role with someone who might be doing more of the psychosocial services, which I think is actually the next question. So it's kind of nice that that was the next question down. Because I do think one of the things I like to think about in this model is that ideally that behavioral health care manager and supported by the psychiatric consultant and PCP is really thinking of this from a biopsychosocial model. So they might be thinking, are there biological things we need to be addressing, psychological treatment that we need to be addressing, but also what are the social barriers for that patient actually improving? I've seen lots of different ways that people work on that now. In some of our pediatric practices, for example, they might partner with a community health worker. We actually use some social work assistants in our system to help really dive into addressing some of those social needs. So I think that may be actually the work of the team, or maybe identified as the team as another need that the patient has, especially that's contributing to their symptom burden or presentation. So that's often really important because especially if patients are having social barriers that are preventing their engagement in care, that's often something we need to address so that patients, can get better. So thank you for talking about that one. Yes, I think those were the main questions. Did I get all of them? You guys can help me look at that.
And I have a question. Have
Yeah.
you had any clinics sign up and do the training and get set up to start the collaborative care model and then back out at some point after that? And if they have, what were the reasons?
Yeah, I think that the sustainment is a really important thing to talk about because I think definitely people have trained and started up this model, and then for various reasons it stopped. I would say the two biggest barriers that I have seen well, probably, yeah, I'll start with those two, are financial. So if you do not think about what is your model for financial sustainment from the beginning, especially given the complexity of our payer system, right? I mean, we're here talking about single payer. So I think most people can recognize, appreciate that that can be really challenging. Before the introduction of the collaborative care codes that I mentioned briefly, there were not good strategies to really get reimbursement for some of the functioning of the team. For example, the psychiatric consultant, if they're only consulting indirectly, can't bill for those services directly, right? So those collaborative care codes are really important. I think that clinics have to build a good, rigorous program that's, they're seeing a large number of patients and getting patients better. Those seem to be really important factors. So if you don't build that caseload, I've seen some clinics sort of their program kind of dwindle down. The other big thing has been turnover in workforce. So if they lose that person who's trained as the behavioral health care manager and have a hard time hiring someone to be back into that role, that can be a real challenge. So that's one of the reasons why I talked briefly about some of our works around developing some additional workforce that could serve in that capacity in Washington State, because we really wanted to think about, are there some ways we can help bring on more workforce that's trained to work in these kinds of innovative ways?
And I may have missed it in your presentation. So when we talk about primary care isn't always just physicians. It can be nurse practitioners, PAs. And can you just comment a little bit on, non-physician providers as part of the collaborative care model?
Yes, great question. So, absolutely. So various roles can be filled by people other than physicians. So when I say primary care provider, I use that term really broadly to be inclusive of MDDO, PA, and AR&P colleagues that all serve in a primary care provider role. That can also be in Washington State. There are additional providers that really have that role or function as primary care providers, and any of them can serve in that primary care provider role. I think it's also important to say that this isn't just primary care. I mean, I think, have, perinatal populations, for example. Those might be patients that would be served in OBGYN clinics, for example. Cancer patients might be served in cancer care centers. We also see implementation of this model in patient populations that have high medical comorbidity, for example, endocrine clinics, things like that, where sometimes the patients often have high rates of mental health distress on top of their chronic illness. So it really can be in any setting where they're sort of following that patient, I think, over time, and really own that relationship of being that patient's medical home. Pediatrics would be the other example of that.
Yeah, I mean, I think that's a great call out because I think as an OBGYN, and then you talk about cancer patients, there's times in patients' lives where they actually don't see their primary care very much, and they're spending all of their care time in front of some sort of a specialty. And one of my colleagues when I was at Kaiser called it the vacation home. Sometimes they're just not in their primary care home, but
Yeah.
for a period of time, they're in some other vacation healthcare home.
Yeah, and I think what we've seen around implementing is that I think whoever is serving in that person's medical home role, like, has to be willing to take on that role of also addressing their mental health needs. And so clinics, there is some variability in how that looks exactly. Again, that's where kind of having those core components be really clear and thinking about how are we going to deliver those if the setting is a little different than a traditional primary care setting. So I think that definitely can be helpful in those settings. And then I didn't say this, but for the psychiatric consultant role, we've also seen that served by both psychiatrists, but also psychiatric nurse practitioners or PAs as well have served as a psychiatric consultant. So we have pretty neutral terms for all of those things because we see a wide variety of workforce serving in those roles.
All right. Well, I think
Peter, go ahead.
Yeah, you go ahead.
Oh, just one question. Paper performance, does this have an effect on how team providers get paid? It often introduces uploading and avoiding upcoding, probably they said, and avoiding difficult patients.
Yeah. So I think thinking about how does this model work in whatever the current reimbursement structure is in your setting is really important, is what we have found. I will say in many clinic systems that are building the collaborative care codes, those are actually built out under the primary care providers MPI. So quite frankly, they get extra sort of RVU benefit for their. So they're usually pretty happy to support the collaborative care billing codes. I think you have to then think a little bit about psychiatric consultant and the behavioral health care manager. If they're in RVU-based models, I think you really do have to think about how are we going to make sure that the incentives are aligned to serve our full population. So I think that pay for performance often does need to be contextualized to the patient population you're serving so that people aren't like cherry picking patients that are easier to take care of. I think there are some ways to do that. I didn't get into a lot of the nuance of the metrics, but I would be happy to have an offline conversation or invite you to one of our office hours at the AIM Center if you want to get into some nitty gritty details around those pay for performance issues.
Great.
All right. Well, I'm gonna have to wrap things up here.
That's
Our time's just about up. Anna can always just go forever. She's great at this. And you're so enthusiastic. Really appreciate that. And we all learned a lot. Um, and our organization, Healthcare for All, will continue our focus on primary care in community-based clinics, something we've done quite a bit of in the last year or so. And then in June, we'll discuss single-payer healthcare in Britain. Please watch for details. And thanks to each of you for joining us tonight. And as the person who usually makes the fundraising plug, please give us some money. We need it for all our good activities, like tonight's webinar, like our uh, lobbyists, like our administrative support. So thank you all for attending.
And thank you, Anna. Thank you again. This was just a powerful idea, and we're so glad that it's University of Washington and your team is leading this nationally. So thank you very much. And thanks to the volunteers that made this available tonight. Thank you all for joining us.
Yeah,
Good
thank
night.
you for the invitation.
Good night.
Good night.